Hello, bonjour. Je m'appelle Anne-Emmanuelle Byrne et je suis professeure à l'Université de Toronto with a specialty in the history of global and international health, surtout en Amérique latine. Aujourd'hui, nous allons discuter l'histoire en période de COVID-19. We begin with a land acknowledgement. We acknowledge that wherever we are located across the continent and beyond, our session takes place on stolen Indigenous land, and we acknowledge the continuities and strengths of the Indigenous peoples of these lands. Since we are meeting on Zoom, headquartered in San Jose, California, we also acknowledge the traditional territory of the Muwekma Ohlone tribal nation. We who are able to connect via Zoom are deeply indebted to the Muwekma Ohlone as the lands and waters they continue to steward now support the people, pipelines, and technologies that carry our sound, images, and words across vast distances. This acknowledgement also covers every link in the chain of production, including of the enormous harms wrought on tens of thousands of child laborers in the Democratic Republic of Congo in extracting the cobalt that is used in our devices. In pandemic times, historians are called upon for more than ever for their commentary and insight, but whether this serves the purpose of escapism, reassurance, ghoulish entertainment, or something policy meaningful remains contentious. Analyzing history in an unfolding pandemic is a tall order for scholars who thrive on perspective and historical distance to element interpretation and enhance meaning, not to mention locate and analyze sources regarding complex phenomena. We bear an enormous, if under-recognized, responsibility in shaping narratives. Par exemple, si nous privilégions les perspectives biomédicales des pays les plus puissants, d'une expérience homogénéisante de la classe moyenne et blanche, ou si nous sommes ouverts à, par exemple, les narratifs d'apprentissage sud-nord, ou une critique des conditions de travail, la discrimination raciale, la dominance des entreprises pharmaceutiques et la dynamique communauté-État. We will explore such crucial issues as why the 1918 Kansas influenza pandemic has emerged as the dominant model for the pandemic trajectory, why and how vaccines serve as a contested endgame for modern pandemics, and we'll unpack the overpowering discourse that is shaped by the most powerful players that reduces the array of societal approaches and underlying factors influencing infection, illness, and death from COVID-19 to quote-unquote non-pharmaceutical interventions. Canada is at a particularly important nexus for exploring these points. The only country that experienced the SARS-1 outbreak in 2003 to not have adequately prepared for SARS-CoV-2, most provinces here do not even seem to have learned much from the deadly and hugely inequitable economic, social, and health impact of how things have unfolded across this year. Today, we have a distinguished panel who will explore these issues from distinct perspectives au Canada et internationalement. I was delighted to be invited to chair the panel, but I do note with disappointment that it does not include speakers from racialized backgrounds. At this perennial time of societal acknowledging and confronting of neocolonialism, global capitalism, systemic anti-Black, anti-Brown, and anti-Indigenous racism, and their interactions with uneven exposure, susceptibility, death, and recovery from COVID-19, deep reflection is warranted. Just as pandemics past and present are lived differently by those with distinct life experiences, so there should be a concerted effort to further amplify the pool of historians writing pandemic histories and invited to venues such as the Société Royale du Canada. This topic begs for more majority world, that is third and fourth world, diaspora, and Indigenous perspectives, including those of junior scholars, and our responsibility in training them. Historians ourselves play a critical role in the call for open science, decolonizing history, and flipping dominant narratives. And now to our speakers. After introducing them, they will each have roughly 8 minutes to speak. We will continue our bilingual discussion through roughly 15 minutes of questions, and then we will open up to questions from the audience through the Q&A function. Nous allons commencer avec Patrick Zilberman, qui est professeur émérite d'histoire de la santé à l'École des hautes études en santé publique à Paris. Il a publié Tempête microbienne, essai sur la politique de sécurité sanitaire dans le monde transatlantique en 2013 de Gallimard. Sa guerre des vaccins vient de paraître chez Odile Jacob. Next, we have Heather McDougall, who is a medical historian at the University of Waterloo, specializing in the history of Canadian health policy and public health. She is the author of the book, Activists and Advocates, Toronto's Health Department, 1883 to 1983, and an online exhibit for the Canadian History Museum entitled Making Medicare. Her many articles examine such topics as the history of Canadian efforts to control the 1918 influenza pandemic in comparison with SARS and avian flu, and the reception of the landmark Lalonde Report in the US and UK. Most recently, she has been researching the history of vaccine resistance and hesitancy with Laurence Monet, with whom she is also preparing a volume on the history of measles and the MMR vaccine in Canada since the 1960s. Ensuite, Laurence Monet, membre de la Société royale du Canada, elle est professeure titulaire au département d'histoire et directrice du Centre d'études de l'Université de Montréal. Elle est également directrice scientifique des presses de l'Université de Montréal. Spécialiste de l'histoire de la santé en Asie du Sud-Est, elle travaille depuis plusieurs années à disséquer les rapports entre médecine et santé au Canada. Son principal projet de recherche actuel, financé par le CRSH, porte sur une histoire globale de la rougeole. Elle a récemment publié Vaccination, le mythe, et The Colonial Life of Pharmaceuticals, Medicines and Modernity in Vietnam. Lastly, Esselt Jones is Professor of History and Dean of Studies at St. John's College at the University of Manitoba. She is the author of 3 award-winning monographs, including Influenza 19, Disease, Death, and Struggle in Winnipeg. Her book, Radical Medicine, The International Origins of Socialized Healthcare in Canada, received the Canadian Historical Association's Clio Prize in Western Canadian History and was recently profiled in the New York Review of Books. She has been a member of the Royal Society of Canada's Task Force on COVID-19 since the spring of 2020 and chairs its public health history and archival preservation working groups. Patrick?
Okay, thank you, Anne-Emmanuelle. And thank you very much also to the Royal Society of Canada to invite me. I will give this talk in French, but I've done slides in both languages, French and English, so Anglophone people can have some possibility to follow what we are talking of. So, je pars du mois d'août 2009, donc en pleine grippe H1N1. Et lors de ce mois d'août 2009, voilà, Margaret Chan donne un grand interview à des journalistes français où elle explique que très inquiet en raison des convergences entre la grippe aviaire qui défrayait la chronique depuis quelques années, d'une part, et d'autre part la grippe qui était nommée à ce moment-là mexicaine, c'est-à-dire la grippe pandémique, les ministres de la Santé sous l'égide de l'OMS avaient organisé la réponse à la pandémie grippale H1N1 en se basant sur l'histoire de la grippe espagnole. Et mon petit exposé aujourd'hui consiste à se demander comment est-ce que la grippe espagnole est devenue un modèle pour planifier la réponse aux pandémies d'aujourd'hui. Alors, la première chose à prendre en considération, c'est que dans le monde de 1918, la grippe n'est pas quelque chose de marginal, c'est quelque chose de central. C'est quelque chose de central parce que c'est d'abord un problème militaire. En fait, en mai-juin 1918, c'est-à-dire dans ce moment où la grippe ne fait pas encore énormément de décès, mais où il y a beaucoup de cas, 75% des soldats de l'entente sont malades. La grippe gêne les opérations militaires et les ambulances ont un mal fou à prendre en charge l'afflux de tous ces malades. La grippe est quelque chose de central, mais est-ce que les contemporains l'ont reconnue pour ce qu'elle était vraiment, c'est-à-dire pour une maladie nouvelle? Eh bien, ça n'est pas venu tout de suite. À l'été 1918, on ne parle pas de maladie nouvelle, nous dirions aujourd'hui maladie émergente, on parle simplement d'une résurgence de la grippe russe de 1889-1890. Et on regarde le risque, en fait, comme bénin. Il y a un premier changement de ton à la mi-octobre 1918, un premier changement de ton en raison de la gravité des complications respiratoires que les médecins soulignent à l'envi. Mais enfin, on n'en est pas encore véritablement au véritable tournant qui reconnaîtrait la maladie comme une maladie nouvelle. Ce tournant, il intervient à l'hiver 1919-1920, quand on s'aperçoit que, quand on a pris conscience plus exactement que la grippe tue des adultes en bonne santé et non, comme d'habitude, des personnes aux deux extrémités de la vie, c'est-à-dire des enfants et des personnes âgées. Donc la différence entre la grippe russe et la grippe dite espagnole de 1918 ne sera clairement comprise qu'à l'hiver 1919-1920. Il y a là un changement de modèle, un changement de paradigme, si vous voulez, mais enfin après coup. La plupart du temps, la grippe pandémique occasionne une surmortalité masculine. Alors évidemment, il y a toujours des exceptions. En 1918, les exceptions sont par exemple l'Espagne ou la Suisse. Mais ce qui m'intéresse, moi, c'est qu'à mesure qu'on se rapproche des territoires proches du front, la différence entre mortalité masculine et mortalité féminine s'inverse. En Meurthe-et-Moselle, par exemple, c'est-à-dire autour de Nancy, on s'apercevra en 1921 que la population compte environ 10% de femmes de 24-34 ans en moins par rapport à 1911. Donc la grippe serait peut-être une explication du recul momentané, mais recul quand même, de l'espérance de vie des femmes pendant la guerre. D'ailleurs, un peu plus tard, des recherches ultérieures détecteront chez les jeunes filles nées entre 1918 et 1920 une propension plus élevée que chez les autres à contracter des maladies ou à faire des accidents. C'est ce que les démographes nommeront plus tard la signature de la grippe espagnole. Alors c'est intéressant sur au moins un point, sur plusieurs points, mais sur au moins un point, c'est que en fait nous voyons bien aujourd'hui que nous ne savons pas prévoir les crises sanitaires de grande ampleur, mais on s'aperçoit qu'on peut quand même identifier certaines de leurs conséquences à long terme, ce qui veut dire que notre capacité de prédiction n'est pas nulle. Alors les contemporains connaissaient déjà beaucoup de choses, en fait. Évidemment, ils ne connaissaient pas le virus, qui ne sera isolé qu'en 1933. Ça pouvait être gênant, naturellement. Mais enfin, ils savaient quand même pas mal de choses sur la contagiosité de la grippe, sur le taux de reproduction, sur le mode de transmission, sur la nécessité absolue d'isoler les malades dès l'apparition des symptômes et sur la notion de cas contact. Je ne développe pas, je n'ai pas le temps. L'intérêt, c'est que sur la base de ce savoir quand même déjà assez substantiel et qui est assez proche du nôtre finalement, sur ces points en tous les cas, les scientifiques s'emploient à convaincre la population d'adopter des mesures barrières, lavage des mains et masques chirurgicaux que nous connaissons bien aujourd'hui. Donc la gestion, si vous voulez, de la grippe de 1918 se rapproche effectivement assez des problèmes que nous rencontrons aujourd'hui et des techniques que nous mettons en œuvre aujourd'hui contre la Covid-19. Il y a une image qui est encore plus proche plus proche de la réalité d'aujourd'hui, c'est la crise hospitalière d'octobre 1918. Octobre 1918, c'est le moment où, à Paris en tous les cas, enfin en France, la courbe prend une allure exponentielle. Tous les services hospitaliers sont surencombrés, et d'autant plus surencombrés que médecins et infirmiers ont été réquisitionnés au front, que les lits sont réquisitionnés par l'armée, et que finalement, les patients manquent de tout, de lits, de médecins, d'infirmières, d'ambulances. Il y a des villes en France qui vont rester d'ailleurs sans médecins pendant des semaines et des semaines. De toute façon, bien évidemment, sans moyens curatifs ou préventifs, les autorités et les médecins auraient été impuissants face à la contagion, mais il y a deux choses intéressantes dans cette affaire. Primo, contrairement à ce qui se passait quelques semaines auparavant, on finit par reconnaître que la population civile a été touchée bien plus durement que l'armée. Et puis encore plus important, certains réclament à partir de ce moment que l'on prépare la riposte aux catastrophes épidémiques de grande ampleur, qu'on la prépare à l'avance. C'est en quelque sorte une espèce de preparedness avant la lettre. Voilà. La grippe espagnole ne peut pas, en fait, malgré ces quelques similitudes, être tenue pour l'analogue historique valable des pandémies grippales qui ont suivi au XXe siècle ou de la Covid aujourd'hui. La grippe espagnole est en fait un événement très particulier, avec un taux de mortalité 5 à 20 fois supérieur à ceux attendus, une proportion plus élevée de complications et de cas graves, une surmortalité dans les groupes d'âge de 15 à 39 ans et 3 vagues successives à bref intervalle. Alors, le choix des analogies pertinentes pour à la fois la compréhension et la gouvernance des épidémies est évidemment d'une extrême importance, parce que chaque groupe d'experts développe ses propres analogies, et puis parce que le débat entre les décideurs se joue précisément sur le terrain des analogies. Un dernier mot, si j'ai une minute, sur la sortie de crise. Elle est tout à fait caractéristique en ce qui concerne la grippe espagnole. En 1921, la crise épidémique est oubliée, totalement oubliée, sortie de toutes les mémoires dès que la crise est terminée. Et en 1957, c'est-à-dire au moment de la deuxième pandémie grippale du XXe siècle, quelques images de 1918 reviendront hanter les responsables, mais enfin, on reste quand même sur la sortie de la grippe de 1918 avec l'existence, en quelque sorte, de deux passés. Un passé vécu personnellement par les gens qui ont été touchés, ou autour de qui il y a eu des gens qui ont été touchés, et puis un passé encore à venir, celui qui est construit par l'historien. Le travail de l'histoire consiste à distinguer entre plusieurs passés, entre au moins ces deux passés, pour les corriger ou arbitrer entre la mémoire collective et l'histoire faite par l'historien. La mémoire collective ne veut pas du passé que lui offre l'historien. Elle ne souhaite ni tout retenir, ni tout oublier. Et la mémorisation collective des pandémies se transforme ainsi en organisation de l'oubli, et c'est ce qui est arrivé à la grippe espagnole. Je dirais un dernier mot, une citation qui, je crois, résume peut-être assez bien notre propos. Elle est de Nietzsche. Sans oubli, écrit-il, il ne pourrait y avoir de présent. Je vous remercie.
Merci, Patrick. Thank you very much for such an eloquent introduction to the history of the great flu pandemic of 1918 and its impact on the past and the present, and of course on the role of historians. As a medical historian who has written on the comparison between 1918 and the SARS outbreak in the city of Toronto, I've been subject to a lot of press requests and media requests for the historian's perspective. And as Anne Emanuel pointed out in her introduction to the panel, a lot of this is a request, I think, for reassurance. And I think as historians, we are happy to provide that. The society and the world do continue to carry on. But are they changed as a result of experiences like this? The other group of people who get in touch with us, of course, are policy makers and analysts and commentators, because of course they're looking for the lessons of the past. And those lessons are sometimes applied, other times they are ignored because they don't fit with the capitalist worldview. And one of the fascinating components of what we, I think, have all been dealing with, all the members of the panel, is the way in which the social determinants of health, which were formalized in 2008 in the Marmot report, the World Health Organization, have come to the fore in 2019. We are no longer simply looking at control of the disease. We are conscious of who it is affecting, the racialized and poor components of society who are bearing the brunt of the disease, along with the elderly, which of course is a marked contrast to 1918. So the question then becomes, what role do historians actually play in all of this? Should we simply be collecting information and responding to the daily changes in case rates and approaches? Should we be seeking to be members of pandemic planning teams and sit at the tables that all of our provinces have created? Or should we stand back and endeavor to interpret for society what we are experiencing and how that has grown out of the past? Because our greatest strengths are, of course, the distance that we have from 1918 and subsequent disease outbreaks, but also our recognition of what the issues were for people at the time and whether we are seeing precise parallels here in the 21st century. Coordination, capacity, and communication have been the real issues for Canadians. Coordination, after SARS in 2003, the Public Health Agency of Canada was created, but it was undercut significantly during the Harper administration. And so although it is the official head, it is still very dependent on Health Canada and on the fact that it is basically advisory. So the provinces in this country do not have to necessarily take its advice regarding the approaches that they're taking. Capacity. Again, SARS indicated that Canadian hospitals, specifically the ones in Toronto, needed to pay greater attention to nosocomial infections and to expand their disease-fighting capacity. But that led then in 2020 to a recognition that although our hospitals have been protected, our long-term care institutions have not. And capacity also, certainly in 2020, although we were to create national stockpiles of protective equipment, that did not function as effectively as it should. So clearly, right from the beginning, there are things that historians are able to observe and perhaps comment on. But I think our biggest role is probably in assessing the forms of communication that have been used during the pandemic. The media, the internet, clearly not something that existed in 1918. But the newspapers in that era did certainly provide information. So how then does communication function in the 21st century? Well, the World Health Organization exists, the Public Health Agency, all of the provincial chief medical officers and the ministers of health and provincial premiers. There's almost a surfeit of information. And that becomes problematic when the messages are mixed and when it would appear to many of the public that it is political gain that is in operation. So historians are going to have a marvelous opportunity to assess all of this once the pandemic ceases to be the dominant news factor. And I think they are also going to, of course, have a great deal to assess in terms of the difference between the non-pharmaceutical approaches, lockdowns, school closures, etc., and the public faith and professional and political faith in vaccines. So that then raises the question of, if historians are being drawn into a contemporary political and policymaking problem, why is it that our insights into the political, social, and economic contextual factors that have led to the situation in which we find ourselves in good times are not actually assessed? And I would argue that the fundamental reason for that is a public and political misunderstanding that prevention is far more than simply disease control. The public is interested in individual stories, not a collective experience. And one of the results of that is that most public health initiatives that result in long-term individual behavioral change and social change, for example, the anti-smoking campaign, take a minimum of 20 to 30 years to conclude. The result of that is there is no sexy, newsworthy story in all of that. And certainly the people that pioneer the initial programs are usually retired by the time that the ultimate social change has occurred. So from a historian's standpoint, our role is, yes, to participate in contemporary debate and offer our insights, but to look for the longue durée, the deep-seated reasons for public health programs, policies, and practices. On to you, Laurence. Merci.
Thank you, Patrick. Thank you, Heather. Thank you, Emmanuel, for this wonderful introduction. I'm really happy to be here and be part of this, I think, much welcome panel. I'll be giving my talk in French, but I'll be happy to answer questions in English. Ma présentation d'aujourd'hui ressemble peut-être un peu trop à un manifeste, alors que je me trouve de plus en plus incapable, je dois l'avouer, d'intervenir dans l'espace public sur la Covid-19, autrement qu'en historienne militante. Et il me semble important de commencer par rappeler une évidence qui a été soulignée indirectement d'ailleurs par mes prédécesseurs, que la santé n'est synonyme ni de médecine, ni de système public de santé. Je suis toujours étonnée par ces approximations, en même temps si révélatrices pour l'historienne que je suis. Et il est incontestable que la crise que nous vivons aujourd'hui montre, une fois de plus, à quel point nos systèmes de santé ont failli, pas juste parce qu'ils ont pris un tournant néolibéral, mais parce qu'ils se sont outrageusement technologisés, qu'ils se sont hospitalo-centrés et focalisés sur le soin individuel depuis les années 70, écartant d'autres façons d'agir, de prévenir et de promouvoir la santé plus largement, qui se sont trouvés à l'époque relégués à l'espace individuel, voire intime. En travaillant récemment, non pas sur la pandémie de grippe de 1918-1920, à la différence d'autres membres du panel, mais sur la dernière grosse épidémie de rougeole qui a frappé le Québec, j'en étais en effet déjà arrivée à ces conclusions. Et cette épidémie qui a balayé la province, et non pas le reste du Canada en 1989, il y a plus de 30 ans donc, nous n'en avons pas pris acte. Ce que notre système de santé imparfait et pas juste sous-financé met également de l'avant, c'est la perdurance d'une verticalité dans l'approche des problèmes de santé. Je dis problèmes de santé et pas maladie. Le concept de syndémie avancé par l'anthropologue Meryl Singer refait certes surface dans certains écrits universitaires. Mais comment peut-on encore oublier que l'expérience infectieuse relève toujours, en même temps qu'elle accuse forcément, un éventail d'inégalités et de vulnérabilité? Comment peut-on se focaliser sur la prévention de la dissémination de la Covid-19 sans agir, par exemple, sur la précarité du logement? À l'égard de cette verticalité ancrée, et comme historienne, je vous avoue être un peu inquiète des récents discours qui annoncent en grande pompe l'arrivée imminente de vaccins. J'attends évidemment moi aussi un vaccin efficace et je connais leur impact dans l'histoire des maladies infectieuses. Mais je vois derrière cette annonce un retour en force de la métaphore guerrière, de l'idée qu'on va vaincre le virus au moyen d'une technologie de pointe. Sans compter que la vaccination pèsera très lourdement sur des systèmes déjà sous-financés. On risque plus largement, à mon avis, très sérieusement, et à nouveau, dans ce tournant vaccinal, d'oublier le gros de l'expérience de la Covid-19 et d'écarter un certain nombre de leçons qu'on pourrait en tirer. On risque finalement de répéter les mêmes erreurs la prochaine fois et de négliger encore les vulnérables, les inégalités, ces déterminants sociaux de la santé évoqués par Heather, et l'importance de soutenir un système de santé où la santé publique, une grande santé publique, pour reprendre les mots récents du philosophe des sciences Mathieu Cortil, à sa place, puisant dans ce que j'appellerais des amnésies très partielles. Qu'a-t-on appris, pour reprendre cet exemple, de l'épidémie de rougeole de 1989 au Québec? Qu'il fallait probablement introduire une deuxième dose de vaccin RRO dans le calendrier, ce qui d'ailleurs a été fait à l'échelle du Canada 7 ans plus tard, en 1996. Mais pas que nombre de non-vaccinations responsables de l'éclosion étaient en fait le résultat de problèmes d'accessibilité à un vaccin de qualité et de compréhension de ses bienfaits. Je me permettrai donc, en historienne mais aussi en citoyenne, de prôner ici une santé publique durable, humaine, intégrée, interdisciplinaire, horizontale et métissée. Ce n'est pas juste la santé mondiale qu'il faut décoloniser, ce que propose par ailleurs avec raison, dans un tout récent éditorial paru dans The Lancet, le médecin et spécialiste de la santé publique épidémiologue Madhu Pai de l'Université McGill et spécialiste de la tuberculose. Il faut non seulement décoloniser, mais débiomédicaliser la santé publique mondiale et celle du Canada. Ce système de santé, cette santé publique auquel j'aspire pour le Canada, aurait pour maître mot l'accessibilité donc. Quand je dis accessibilité, je pense d'accès géographique, économique, ce qui paraît assez évident dans un système public de santé, mais aussi culturel à des façons de prendre soin et de prévenir. Un système qui ferait, je voudrais dire en somme, mais en fait c'est plus large que ça, place à l'éducation continue de tous, pas juste des malades, pas juste des jeunes, pas juste des profanes, des professionnels de santé aussi. Éducation aux gestes barrières essentiels, aux déterminants sociaux, qui inclurait cette santé publique durable, cette grande santé publique, transparence, communication et surtout d'abord dialogue entre acteurs et pas seulement entre experts. Un système enfin qui serait puisé dans des réflexions et des initiatives passées et étrangères. Celle en promotion de la santé, en santé communautaire, en soins primaires, Alma-Ata bien sûr en 1978, mais aussi ce à quoi je pense depuis quelques mois, aux initiatives en santé rurale, au cœur de formidables conférences internationales dans les années 30, de Paris en 1931 à Bandung en Indonésie en 1937, qui se penchaient déjà sur la meilleure façon d'intégrer soins et prévention et sur la meilleure façon de mobiliser pour ce faire une diversité d'intervenants, médecins et non médecins, professionnels de santé et non professionnels de santé. Des réflexions et des initiatives passées qui, en outre, chacune à leur façon, ont promu une recherche interdisciplinaire, entre professionnels de santé en sens large donc, mais aussi aux côtés des humanités et des malades. Je finirai en disant qu'il est tout aussi important, d'où ma mention d'ailleurs de la conférence de Bandung en 1937, de regarder ce que les autres font, les initiatives d'ailleurs. Je travaille sur le Québec, le Canada depuis plusieurs années comme historienne de la santé, mais je suis d'abord, comme Anne-Emmanuelle l'a rappelé, une spécialiste de l'Asie du Sud-Est. Et en tant que spécialiste de l'Asie du Sud-Est, je vois une approche trop nationale, voire trop nationaliste de cette pandémie. Approche intrinsèquement paradoxale qui en même temps, bien sûr, se justifie. La santé publique, c'est une affaire d'État. En l'occurrence, au Canada, c'est une affaire d'État provincial. C'est aussi une affaire de réalité très localisée. Mais je pense qu'il nous faut maintenant, enfin, regarder aussi ce qui se passe en Corée du Sud, au Sénégal, au Cambodge, où je travaille sur l'histoire de la rougeole, ce qui nous permettra de mieux comprendre et donc de mieux agir dans l'avenir et dans le futur des pandémies, parce qu'elles existeront toujours, avec humilité, mais d'abord avec efficacité. Je vous remercie.
Thank you, Laurence. I'm going to speak a little bit before I start talking about my own research perspective about the very important issue that Anne-Emmanuelle raised in her introduction regarding reflecting a diversity of lived experiences in our discussions about COVID-19 and history. I just want to point to the broader conference today, which reflects, I think, the fact that some of us on the RSC's task force steering committee early on felt that we needed, for example, Indigenous scholars to be at the table on the steering committee. And I was very pleased with the response of the RSC to that concern and their commitment to making inclusion happen. So running parallel to ours or concurrent to our session is one including Chantal Richmond, who is a Canada Research Chair in Indigenous Health and the Environment at Western University, and is chair of our Indigenous Working Group on the task force, who have been working hard for several months and have issued a report on Indigenous responses to COVID that's available freely on the RSC's website. So I hope also that people who are listening to the Public Health History panel will also perhaps have an opportunity to look at the recording of a panel that Chantal is on with others on Indigenous responses at the same time as ours. Following our sessions is a panel around the working group led by Carl James and Francis Henry, which published 11 essays on the impact of COVID in racialized communities in the Globe and Mail. And these are also available on the RSC website. So I agree that there is a long way to go, particularly, I think, within my own discipline. In terms of improving not just representation, but the analysis that needs to follow from having different voices at the table. But I do think in terms of conferences that the RSC has done in the past, this one probably reflects greater diversity than has been the case. And I think that's very important in the context of COVID-19. I'm also really happy to be part of this panel, which is almost entirely women. I don't think that that would have happened early in my career. I think it's a reflection of at least some movement toward a greater inclusion of female voices. So I want to get back a little bit to the question that Heather was talking about as well, about how do we respond to the challenge to speak to history in the context of COVID-19, and what do we say when a journalist says, what are the lessons? And Patrick's presentation really illustrated for me why those questions are so discomforting for us as historians. The point he raises about the morphing of history into an analogy, or this idea of the organization of oblivion. So how do we walk that balance between remembering and forgetting, and how do those decisions get made? And I think all of us feel uncomfortable with speaking about lessons, partly because although Patrick articulated it much more clearly than I've ever been able to, I think that's what explains our reluctance to some extent. At the same time, I want to recognize that a lot of forgetting of the influenza pandemic in Canada was done by historians themselves in their roles as handmaidens of the nation state. So influenza, for example, wasn't a good story when lined up against the Battle of Vimy Ridge in the story of nation building in Canada. The flu did, of course, leave a scar on millions of people whose lives it impacted, especially those who were most vulnerable to the disease because of colonialism, economic and social inequality, and the gendered nature of both the disease and its aftermath. And the pandemic certainly wasn't the same event for everyone. Its legacy wasn't equitable. In my experience, many individuals and families that were most impacted by flu did remember it, but had no larger collective memory into which they could place their personal experience. So that the burden of influenza was disproportionately borne in society was essentially forgotten, and arguably remains forgotten even until today, when scholars are still struggling, for example, to get good data on social inequalities and questions of race, for instance, and still arguing the relationships between inequality and the pandemic experience. While we've been writing a policy paper on public health history in Canada, by taking this longer term perspective, I've actually been struck by the limited way then in which the flu pandemic did operate as a learning experience or a watershed in public health. So that forgetting operates on multiple levels. But I do think it left some legible traces on disease control practices, especially in relation to the need for greater public cooperation and engagement. And it deepened an already existing movement against compulsion, enforcement, and posed an explicit challenge to quarantine measures, which officials at the time believed to have failed. I want to speak a little bit here about Manitoba, where we now have the highest rate per capita of COVID in Canada, and where policing and enforcement have become front and center in public health responses. In 1918, public health measures in Winnipeg focused first on knowing who and where the infected were, and health officers didn't want people to hide. They wanted them to come forward and report their cases. So they avoided creating measures like the placarding of homes where the infected lived, for instance, because these were experienced as stigmatizing and unfair by many people. So as the number of cases in poorer neighborhoods escalated, public health did try to maintain communication with affected neighborhoods, working extensively, as Heather's noted in her work, with community organizations and volunteer groups. They encourage sick people to voluntarily report their illness and then do their best to self-isolate. But these policies were pushing uphill against social conditions that, of course, facilitated the spread of the virus. Overcrowded and poorly ventilated housing, a lack of hot running water, poverty, low wages, lack of savings that might tide a family over while self-isolating. And those are conditions in urban centers, which is what I've done most of my work on. As flu cases escalated at the end of October of 1918, public health officers, though, faced a lot of pressure to heighten enforcement. So the provincial medical officer adopted an increasingly aggressive public position, accusing alien residents, that is non-naturalized residents in rural Manitoba, of concealing cases of influenza from the authorities. And Fraser insisted that the public should, quote, observe the strict letter of the law or face prosecutions to the limit. Now, influenza slowly ran its course over the month of November, but the quarantine measures that were called for really proved impossible to implement, with many infected police and other enforcement personnel and hundreds of new cases every day. When the pandemic had passed, public health officers across Canada reflected on the effectiveness of these measures and others. Edmonton's public health officer, for example, spoke of public skepticism and suspicion about the province's extensive use of compulsory edicts. Some called for a pragmatic recognition of the limits of quarantine, for the creation of public health laws that emphasized cooperation and limited use of coercion and punishment for violations. By the late 1920s, the Minister of Health in Saskatchewan argued, in the protection of the public health from the inroads of preventable and communicable disease, it's necessary that restrictions be placed upon the liberties of the infected individuals. Yet after years and years of the applications of restrictive measures, no indications exist of their efficiency. So health officials developed tools of health education and stronger community relationships because they knew such tactics like placarding homes and policing isolation could serve to undermine broader disease containment efforts. And they also call for more resources for things like vaccine research, development, and broader public access to prevention, especially in rural areas of the country. It's difficult to say that strict enforcement will stem the spread of COVID-19 in Manitoba, but it does seem to me to be unlikely. The reasons for COVID's persistence are complex, and a multifaceted approach is really important, including a dual strategy of following basic public health measures, hand washing, social distancing, staying home when sick, and measures that address social inequity, poverty, racism, and poor housing. Perhaps the greatest risk to ramping up enforcement is that it will further erode what is a very fragile public consensus now around painful measures needed to stop the spread of the disease, and that this may be especially true among those who experience regulations and enforcement as unfair, arbitrary, or simply undoable. Pandemics are inherently social, and our solutions have to come from a sense of shared responsibility, not blaming individuals. I do think this was a lesson that was taught in 1918-19 that I feel comfortable as a historian asserting. Living through a pandemic as a historian isn't the same about writing about it as a past one. The emotions are different, and the urge is there to act and to contribute. driven by a broader sense of responsibility to those who are made vulnerable by the everyday injustices in a society that we have yet failed to transform. Thank you.
Thank you so much to each of our panelists for their thought-provoking reflections. And now we have time for questions and answers among us, and also invite the audience to participate through the Q&A function. So let me begin by coming back to a theme that various of you presented around militarization, policing, whether through metaphor or enforcement, and also the association of pandemics with war. So we're familiar with this language, as Susan Sontag put forth, around combating disease as a collective effort against an enemy. But what would you argue as historians are further risks, even around this association of policy with policing, or, for example, the extensive use of the military forms of surveillance, securitization, and funding for research into pandemics? I don't know, maybe Laurence wants to begin, and then we'll go around.
Thank you, and Emmanuel, for this important question, I think. I use the word vertical, and I think it's my background in global health that makes me use it. And I don't think the war metaphor is not good in itself. I mean, it could be useful. It could help people understand what they have to do, what they're doing, right? So it's like very performative in a way. At the same time, what bothers me over and over is that idea that we deal with one virus at a time, and that the ultimate objective is to actually get rid of it. You know, I mean, we could talk about the history of educations and everything, but I think the main issue is there, the fact that we're just so focused with, you know, virus extinction that we don't look around, and we don't, you know, take into account social determinants of health and housing and nutrition. And we've done that over and over since the late 19th century, right? And I just don't know what to do with that. So I will leave it there.
Others? Heather, Patrick, Esselt?
I'll just briefly add the connection in my mind between enforcement and the military metaphor with scapegoating and stigmatizing of certain sections of the population. And that's always fluid, who those people are going to be, who get blamed. But the use of the concept of an enemy, which is central to the military metaphor, I think facilitates the search for the enemy. But, you know, maybe Laurence, what your work is suggesting is that, you know, the enemy really is, you know, it's us to a significant extent, right? It's the way we organize our world. It's not a specific person or a specific group. It's our failures to address those things that you talk about.
I think that for most of the people in 1918, the war was the most pervasive reality. So it's not a huge surprise that their rhetoric reflected that. And the interesting thing about looking at the Ontario situation in 1918 is that the province's chief medical officer was also in charge of the military hospital and healthcare activities for pretty much the province of Ontario. And of course, we were still shipping troops over to the Western Front and bringing people back. And so you actually see this, and I think this is true all the way across the country, that any provincial people who weren't actually over on the Western Front were doing double duty. And so it's, as I say, not a surprise that their rhetoric would reflect what was top of mind for them, and yet their dual responsibility to care for the civilian population. What I have found striking about 2020 is the use of the Canadian Army in long-term care and retirement homes in the provinces of Ontario and Quebec. And one of the more interesting comments from the reports that came out was that they were shocked by the lack of organization in the civilian facilities that they were part of. So it also speaks, I think, to the place of the military in Canadian society. We expect it to rescue us from natural disasters like power outages, floods, snowfalls, and now illness. And that's a significant shift from the early 20th century, when it was in theory overseas and defending us from an external human enemy. The issue of compulsion that Esselt raised is crucial, because when you look back at the 19th century, Canadians were much more interested in the British model, which really relied on persuasion rather than coercion. And so it was very, very difficult to get bylaws or provincial legislation that actually made anything mandatory. And I think that the deep communal memory of that is a factor in a certain amount of the resistance today, but it was paralleled by strong emphasis on collective responsibility. And certainly in the war, that was the dominant feature in Canadian society. And one of the things that I have always wondered about was whether, if Canadian society faced a similar challenge, would we see the same kind of collective responsibility? And a panel I was on yesterday, actually, the First Nations psychiatrist who's out at the First Nations Health Authority in BC now as the deputy medical officer, made the point that she thinks that 80% of the Canadian population actually is on board with the health regulations and practices that Esselt outlined, and that the challenge for people in the field is, of course, the 20% who are not quite as into collective responsibility as the vast majority. Mm. So, as I said, I think for historians, this is an amazing opportunity both to reflect on our own lived experience, but also to compare what ostensibly is going on now with what we know about what happened in the past.
Thank you. So we'll circle to Patrick next, perhaps on this question, but also since you raised the issue of comparisons, we are dealing not only with past-present comparisons, but also with global comparisons, perhaps now more than ever. And certainly many of us wake up on a daily basis with the Johns Hopkins platform that erroneously, in many ways, since it doesn't include denominators, shows us who is in this deadly horse race to be first in terms of infections and deaths. So I want to ask Patrick first, and then others, certainly Laurence. How you think that the global comparisons of who's locking down, who's making progress, can be historicized? So is there a historian's perspective, a lens on this that can shed light that's more sophisticated, more useful than the Johns Hopkins platform? Patrick?
Yes, we in fact both issues, the issue of compulsion for one, and the issue of global approach of epidemics or pandemics are closely linked. I was very stricken during the months of March and April to hear from many people, at least in Western Europe, a very satisfactory, self-satisfactory idea about compulsion. People wanted that China would be the leader in what we have to do, in what we had to do to stop the epidemic. And I was really horrified to hear people giving a lot of satisfactory remark to the Chinese authority and to anything that would reinforce the compulsory politics in any way. For instance, take some issue which is rather ridiculous. The mask, for instance. The mask has become an issue where people wanting more compulsion and people hating any kind of compulsion are discussing between them. And I think that the rehabilitation of compulsion or even coercion is something very important in the first part of the COVID pandemic. We'll see that in the second part, in the future, if those coercive ideas would develop themselves or not.
Laurence, perhaps you can engage and challenge some of Patrick's comments here from the perspective of Vietnam, maybe Taiwan. Is this a question of compulsion versus collective engagement, or is there another issue of trust and confidence in leadership, for example, that's playing out?
Right. Wow, it's a tough question, Emmanuel. But no, I think compulsion has a different meaning in some countries, especially in East Asia and Southeast Asia. And I'm not saying it's a cultural thing, and mask is not a cultural thing either. But the relationship between the state and public health has grown differently. And I'm going to take the case of Vietnam. I mean, Vietnam has had, the experience of several pandemics in the last decades or so. I mean, SARS, but also H1N1 and H1N5 and the flu, the avian flu. And they have learned to actually, act very quickly and very thoroughly. And compulsion is a part of that. I mean, the fact that people had to quarantine from February on, the fact that, nobody could travel from Vietnam or get in. And everybody was like, oh yeah, but it's Vietnam. It's just, it's an authoritarian government like the Chinese one, but it's a bit more complicated than that. And I'm going to go a little bit further and go back to the question you asked about, global health perspective and how we should, engage with the fact that we are in a global pandemic, and as historian, what should we do about that, right? And something I think is very positive, actually, it's slow, but it's growing. The fact that we are, and not just historians, but as academics, intellectuals, but also part of the civil society and the state, I hope, we are in the process of rethinking two divides, the North-South divide, and what I would call the East-West divide. I don't like it, but it just, for the purpose of the discussion here. And I think historians in particular have a huge role to play in this new narrative. And I'm just going to mention my newest project on the global history of measles. Nobody cares about measles. Heather knows we've been working on measles for quite some time. And until recently it was like, oh, you're working on measles, why? But because it's a very interesting global history to actually write. And that new project, and Heather is involved with it too, it tries to actually, look at different spaces and places and communities, what we say in French, à parts égales. So it's not how the US or Canada looked at measles and defined, for instance, that measles was a tropical disease in the 1960s in West Africa. But it's to go back to West Africa, for example. That's one of the example we're looking at. And to see how vaccination in some countries, especially in the Gambia in the 60s, became a model for the US to actually defend their vision of measles eradication, which is fascinating, actually. So that's kind of things like, we're thinking that, twofold divide, and hopefully that's what we are in the process of doing, and I'm happy we're doing it.
Thank you. And of course, there's enormous diversity and experiences even within regions. So the part of the world where I work, Latin America, is highlighted for the very difficult situation in Brazil, in Mexico, and the Andean countries, but also has exemplary experiences such as those of Cuba, of Uruguay. And these are experiences that get homogenized, that get silenced by some of our continued, and I'll use the term again, colonizing narratives around the way not just pandemics unfold, but life writ large. We really need to open up to our larger audience. I want to give Heather and Esselt literally 30 seconds each to give 3 pros and 3 cons of historians being invited to the policy-making table. Heather?
Oh my goodness. Okay, first of all, I think historians would be useful to deal with the issue that Patrick mentioned about analogies. We will give them context and the human aspect of all of this. I think our presence would help counterbalance the excessively technical scientific approach to decision making that often dominates at specific policy tables. We will remind them that there will be unforeseen consequences to the decisions and policies that they make and implement. In terms of cons, the biggest danger is that when you are invited to participate in something like a pandemic planning table, it's very seductive. You get caught up in the moment and in all the action, and often you will display perhaps a little less rigor in assessing the evidence that you are presented with as part of the decision-making process, because the public health people have been told that they need to make a decision even with inadequate evidence. Esselt, over to you.
Heather stole all my good ones. I mean, the humanism part is very important for me in my work. And also the possibility of talking about the long-term consequences of a crisis moment, and to explain to people that COVID-19 will last a lifetime for those who are most severely affected by it. It's also important, I think, or beneficial to talk about the choices that societies make at different moments, and good, bad, and otherwise, you know. I think the downside maybe is something related to Patrick's remarks, which is that, you know, there's always a risk that the analogy that people pull out of historical work isn't the analogy that you would choose. And the power of those metaphors and analogies can be very counterproductive. And that I think is always a worry. And my colleague, Mary Jane McCallum, often talks about needing to stay, you know, in the record and in the experience for long enough to be able to do more than just provide a convenient analogy, right? To provide greater insight than that.
Thank you. And now on to the public's questions. All right, so I invite co-panelists to put their video and mics back on. We have a couple of thoughts and questions. One, I believe it's tongue-in-cheek, although I take it quite seriously, and that's asking Laurence to share her manifesto for historians so that we can sign it and circulate it. So we'll see where that goes. But more seriously, we have Cheryl Warsh's question. Are there any discussions on demographic consequences at the policy table? During the Spanish flu, young adult women's susceptibility led to widowhood, orphanhood, and remarriage, all of which had consequences. Perhaps the focus on the elderly and their lower impact on long-term demographic change has lessened that focus. So the floor is open for co-panelists to speak. I don't know, Esselt, if you want to start us off.
Sure. Quite a bit of my work has tried to argue the benefit of looking at epidemics beyond the moment of crisis, to evaluate long-term consequences on familial life. But I think this is a key difference that Cheryl is highlighting potentially between the social impact of COVID versus the 1918 flu pandemic. Because the demographics of, you know, who the vulnerable groups are, who are dying in the highest numbers, are very different because of the classic W curve of the 1918 pandemic, which saw a lot of people between 20 and 40 die, many of whom had families. We're also dealing with slightly different gender relations, although not so different, I suppose, in the greater impact that women face. But in 1918, you know, women had very few employment opportunities. And so the financial impact of losing a male breadwinner for female-led households was extremely significant and life-changing for many families.
Patrick, you want to respond?
Yes, rapidly. I touched some demographic problem in my talk. That was the relationship between the fall of female life expectancy and the flu during the war. Of course, this fall of female life expectancy can be attributed to some other cause. Problem about food, for instance, problem about dwellings, etc., etc. And of course, problem about industrial works, because a lot of women were more or less obliged to take work in manufacture, and these working ambiance was not really satisfactory from the health point of view. But there were also other problems. French demographers were absolutely engaged in the flu question, especially after the war. And for instance, they work on another important question, the fact that there was no correlation apparently between flu mortality and urban sociology. At the beginning, where statisticians try to put their inquiry into publication, they saw that rich neighborhoods in Paris were count more deaths than poor neighborhoods. And the solution of the problem was very easy, in fact. It was not the problem of density, of problem of socio-economic level of the population, but a problem of overcrowded dwellings. And so there was in the 7e arrondissement, for instance, which was a rich neighborhood, a lot of female deaths because many 20 to 30 age single women in Paris, what the French called les bonnes, lived in those badly ventilated rooms and badly heated rooms, and they were very poor, and 25% of the female felt by the flu in Paris were of that category. So there was a whole array of demographic problem that were treated mainly after the war.
Heather?
The latest research that I've seen is quite interesting because they were looking at the question of pregnant women during the COVID. And the conclusion is that of this one fairly small scale study, that it hasn't had a huge impact in terms of causing either maternal complications or low birth weight babies. What I suspect they can't take into consideration right at the moment is the impact of stress on women who are expecting children and the women who are caring for children and spouses and elderly parents, etc., over the course of the outbreak. But I think it is, given the concern manifested at the beginning of the outbreak about fears that we would be in a situation similar to 1918 when many pregnant women miscarried or died in childbirth and often the baby with them. So there was concern about whether or not that had to be one of the factors. But long-term, I think, yes, there will be demographic impacts, but that tends to be something that anthropologists more so than historians take a look at.
Mm-hmm. Mm-hmm. Laurence will give you the final word here.
Oh my God. On the flu, you mean I have nothing to say about the flu?
Okay, then give us the final word on the panel and on your manifesto.
Yeah, my manifesto. I mean, I didn't think about it like it was a manifesto, but sure, it actually is. I think, and the panels show that, and I'm glad the Royal Society decided to have a panel on history on COVID-19. I think it was a great idea. What it shows is that we have to actually talk to each other, which is like, you know, we know that, not just between historians, but also with other experts coming from a various range of disciplines. And I'm talking about social science and humanities, but I'm also talking about health experts and of course, people in politics. And the other thing is, and we talked about that earlier, the idea that we can't have just a national history of COVID-19. We have to find a way to actually talk to people who don't work on Canada. And it's not, by saying that, I'm not saying it's not worth it to work on a national history of COVID-19. It's extremely useful, but we have to have a dialogue, and we have to have it very soon with people who work on Europe, but also on Asia and Africa and Latin America, and also in a way, I'm going back to your introduction, Anne-Emmanuelle, we also have to think about the relationship between majority and minorities. And a way to do that is to just, not focus on the issue being a geographic one and a national one.
Well, with that call for more dialogue and complex narratives and subaltern narratives, we will close our panel. Thank you so much, both to our panelists and our audience, and stay in touch. Thank you.